Good morning. Today I'm going to discuss a very hot topic, which is diabetic kidney disease update under the title of Diabetic Kidney Disease Today. So I reviewed more than 150 manuscripts, and I'm going to present their digest under the following two topics. So this presentation will discuss pathophysiology, pathology, and clinical arenas. And next presentation will discuss the hot issues in the update in the management of diabetic kidney disease. Let us start the first presentation, pathophysiology, pathology, and the clinical arenas of diabetic kidney disease. I'll discuss this issue under the following corners and sectors. Why diabetic kidney disease? What is the importance of diabetic kidney disease? And then the pathogenesis of diabetic kidney disease. What about the presentations, different issues in presentations? What about pathology of diabetic kidney disease? And I'll discuss in this sector diabetes and the living kidney donors, so diabetes developing after kidney donation, risk factors, and implication on the patient and the donor outcome. And then I'll close this presentation. Let us start with why we are interested in diabetic kidney disease. This is a cohort including more than 500,000 persons, and here the total cohort is 512,000. Reference population non-diabetic and no CKD in 400,000 persons. Diabetes without CKD in 18,000. Early chronic kidney disease without diabetes 50,000, and 9,000 early diabetic kidney disease. By early, I mean diabetic kidney disease with a stage, chronic kidney disease stage 1 to 3. This means estimated GFR between 30 to high to normal GFR in a diabetic person. And early CKD without diabetes means stage 3, 1 to 3 CKD without diabetes. So let us go to the results. So the hazard ratios for all cause and cause-specific mortality by diabetes and chronic kidney disease status are summarized in this table. You can look at the reference, always the hazard risk is 1, and then diabetes without chronic kidney disease, you'll find here higher hazards in some parameters, some variables. Early CKD without diabetes, again, you can look at the hazards. And if you look at early diabetic kidney disease, you'll find the hazard risk is increasing for the majority of variables in comparison to the other sectors. So in comparison of early diabetic kidney disease with early CKD without diabetes, you can look here, everything here. This is the all-cause mortality, cardiovascular, stroke, coronary heart disease, respiratory system. All these are higher with early diabetic kidney disease. Comparison of early diabetic kidney disease with diabetes and without CKD, you can find here again early diabetic kidney disease associated with poor outcome. And here in comparison, early diabetic kidney disease had higher mortality across all estimated GFR levels. Even if we look here at the normal GFR, the presence of early diabetic kidney disease is associated with higher mortality. So all through the GFR, estimated GFR ranges, the mortality is higher within the patients with early diabetic kidney disease. And here again, early diabetic kidney disease had higher mortality across all levels of proteinuria. So here, if the proteinuria is negative, trace 1 plus or 2 plus, you can find here the presence of diabetes with these degrees of proteinuria is associated with higher mortality. Early diabetic kidney disease had higher mortality across all fasting glucose level. So the presence of early diabetic kidney disease is independent on the values of plasma glucose in causation of the mortality. Early diabetic kidney disease had higher mortality across all systolic blood pressure. If you look, early diabetic kidney disease, irrespective to the level of systolic blood pressure, is associated with higher mortality. And if we look either in men or women, you'll find here, this is the reference, no diabetes and no CKD, and this is the early CKD diabetes without CKD and early diabetic kidney disease, what the life expectancy is adversely affected and shortened by the presence of the early diabetic kidney disease, as you see here. Even you can find here in women, this is 60 and this is 44. This means 16 years reduction in life expectancy. So it is very important. And if we compare the presence of diabetic kidney disease to the lifestyle here, if the patient is inactive, inactivity is associated with increasing hazard risk. And again, if there is early diabetic kidney disease, the higher risk of mortality is increased. Again, even if the patient is a smoker, prevalence of diabetic kidney disease is adding to the mortality rate difference per 100,000 person per year. And for the alcohol drinking, again, diabetic kidney disease associated with more mortality. And even with obesity, there is increasing trend for increasing mortality in the early diabetic kidney disease. So this gives us an idea about the early diabetic kidney disease and its affection of the patient's survival. So early diabetic kidney disease adversely affect the outcome. Regarding the Biobank Japan cohort study, including 30,000 Japanese patients with type 2 diabetes, here all these are associated with the other ratios of risk factors for mortality of patients with type 2 diabetes. You can find here. All these are significant. The sex, age, A1C, hyperglycemia, high blood pressure, and here this is the chronic kidney disease. The hazards crude analysis is hazard ratio is 2.48, and multivariate analysis is twofold. Again, it is very significant. And here smoking is bad, either an ex-smoker or current smoker in comparison to non-smoker. So again, in multivariate analysis, current smoker is associated with very important increase in hazard ratios. So it's better to avoid chronic kidney disease and avoiding smoking in patients if we can, in patients with diabetes. Again, the presence of diabetic kidney disease is bad news in Japan too. Regarding pathogenesis, this is a very nice review discussing the update in diabetic kidney disease, challenges, progress, and the possibilities. If we look at these are the factors, risk factor for diabetic kidney disease from susceptible. So if you find a plus, this means susceptible factor, and initiation factors and the progression factors. So we can look at old age, sex, race, familial history of diabetic kidney disease, genetic kidney disease, hyperglycemia, obesity, hypertension, acute kidney injury, toxin, smoking, and high protein intake. And you can look at the correspondence, so you can find the majority are factors of susceptibility, and some of them are initiating factors like genetic factors, hyperglycemia, hypertension. All these are initiating factor. And then the hyperglycemia, obesity, hypertension, toxins, smoking, high protein intakes are within progressive factors. So if we can know the factors and we can modify, so it's better to look at these factors and to discriminate them into either modifiable, partially modifiable, or non-modifiable risk factors to give ideas about the preventive tools in the management of diabetic kidney disease and diabetes in general. So here, this is the theoretical backgrounds of pathophysiology in general of diabetic kidney disease, either pathophysiological factors, hemodynamic, like increasing renin-angiotensin aldosterone system, TGF-beta, endothelin, metabolic, increasing ages, advanced glycation end products, reactive oxygen species, here fibrotic factor like TGF-beta, vascular endogenous factor, increasing collagen, connective tissue drive growth factors. All these are within the pathological factors, and I'll present some data regarding all these pathophysiological factors in next slides. Intracellular signaling pathways, all these are pathways involved, and in transcription factors. At the end of the day, we'll find the brand of diabetic kidney disease, glomerular hypertrophy, mesangial expansion, tubular interstitial fibrosis, glomerulosclerosis and kidney fibrosis, and ultimately end-stage kidney disease at the end. So let us start with one of the factors, with the genetic. So if we look at the genetic landscape of renal complication in type 1 diabetes as presented in this study, the score for genetic correlation between smoking cessation and reduction risk of diabetic kidney disease in subject with type 1 diabetes is highlighted in this study, supporting the previous research finding of smoking as a risk factor of diabetic kidney disease. Altogether, these results may provide valuable clues to the biological process relevant to the pathogenesis of diabetic kidney disease. And this slide shows the genetic risk scores for body mass index and type 2 diabetes were associated with diabetic kidney disease phenotypes in subjects with type 1 diabetes. So it seems that there is impact of the genetics. So by development and evolution of genetic studies, we can understand some issues related to this phenomena. This is a meta-analysis of 2,100 participants from 5 studies showing that Aldose reductase gene polymorphism may be correlated. So the presence of C10-6T gene polymorphism may be correlated with diabetic kidney disease and diabetic nephropathy. So, and this is the meta-analysis. Here you can find increasing diabetic nephropathy risk. Here this is a forest plot with this polymorphism in the Eastern Asian population with type 2 diabetes under an additive genetic model. So you can find here T versus C, and so you can find this polymorphism is associated with higher risk of the diabetic kidney disease. And these are the alleles, bold odds ratio, and the p-value for the significant correlation with this gene polymorphism and diabetic nephropathy in Eastern Asian population with type 2 diabetes. So you can fix and look at the genetic polymorphism. So it seems that knowing a lot about the gene may be important, and moreover, regarding epigenetics means interaction with the genes, environmental interaction with the gene. So this study and other studies emphasizes the role of epigenetic modification that may play a role in regulation of renal fibrosis and macrophage infiltration, thus may be put in mind when we think of therapies. So here, escolitin ameliorate insulin resistance and type 2 diabetic nephropathy through reversal of histone H3 acetylation. So this is a reversal of post-translational histone modification, and modification of epigenetics may open the horizon for the management of diabetic kidney disease. Another interesting point, which is probiotics. Propofol ameliorates renal injury in diabetic nephropathy by inhibiting the expression of redox enzyme B66SHC, which is another form of epigenetics. So if we look here, you can find the addition of propofol to this diabetic kidney. It modulates diabetic kidney disease, and this slide summarizes the mechanism behind the propofol, which is anti-hyperlipidemic agent and the potent antioxidant drugs that can delay the progression of diabetic nephropathy and reverse renal oxidative stress in diabetic animal models. Here, the presence of hyperglycemia inhibit this molecule. So when we give propofol, it will stimulate it, and at the end it will manipulate these gene products. At the end of the day, propofol will reduce reactive oxygen species, apoptosis and fibrosis, and ameliorate diabetic nephropathy. It may be a factor of epigenetic as well. Another important factor, which is obesity in general. Obesity is associated with kidney disease, as shown in this fascinating review. If you look here, either we have visceral adipose tissue leading to all these factors: endothelial dysfunction, increasing RAS activation, increasing vascular stiffness. At the end of the day, you'll find the print of the obesity on the kidney tubulointerstitial damage, and ultimately chronic kidney disease and end-stage kidney disease. Obesity is well known a risk factor for diabetes. So if we take the data together, we may put a hypothesis of preventive arena is to guard against obesity. And this is a very interesting point. Gastric bypass surgery stimulate the dormant gut-brain axis in obesity. So if we understand the issue of gut-brain, we may do a good job. So to truly reduce rates of chronic kidney disease, a root cause of kidney damage, obesity must be targeted. Weight loss is often unsustainable because imbalances in satiety regulators are frequently not addressed to ensure maintenance of weight loss. In a recent study, gastric bypass surgery rebalanced satiety signals through resensitization of the gut-brain axis in obesity. So this is a very hot research that may lead to non-invasive strategies to reduce obesity and obesity-related kidney disease if we discover drug that ameliorate and normalize gut-brain axis. Another interesting pathways that correlates neurology with inflammation, beta-2 adrenergic receptors in inflammation and vascular complication of diabetes. Here, if we have diabetes leads to instability of inhibitor of kappa beta, of factor kappa. So destabilization of this factor will lead to increasing activity of nuclear factor kappa beta, leading to increasing inflammation and kidney disorders. Here, the stimulation of beta-2 receptor, adrenergic receptor, stimulate BRSTIN2, and the BRSTIN2 stimulate the inhibitor of kappa B, and the stabilization of this inhibitor will reduce the inflammation and reduce in nuclear factor kappa beta. So this pathway open the horizon between adrenergic receptor stimulation and the inflammation and the vascular problems in diabetes, and they may be related to the inflammatory macrophages because we have M1 and M2 macrophage, and one factor in the evolution of diabetic kidney disease is imbalance. So M1 macrophage type 1 is bad because it is inflammatory macrophage, and M2 anti-inflammatory. So in diabetic kidney disease there is imbalance, increasing M1 and decreasing M2. So the knowing well the pathway of neuro and inflammation may ameliorate all these problems. Another factor which is advanced glycation in the products. So advanced glycation in the products in experimental animal showed correlation with diabetic nephropathy, and amelioration by the use of anti-ages ameliorate renal fibrosis and diabetic kidney disease in animal. Another important role is the pathogenetic role of complement in hyperglycemia-induced renal injury. Under normal conditions, mannose binding lectin or feculins don't bind to the receptor on cell surface. However, in diabetes, advanced glycation of protein in response to hyperglycemia generates new epitopes to which lectin pathways pattern recognition molecules bind. In addition, accumulating data indicate that increasing level of glycation in diabetes leads to glycation-induced dysfunction or inactivation of complementary regulatory proteins such as CD59. So CD59 is a complementary regulator protein which is inhibited in the presence of hyperglycemia. So diabetes inhibit this complementary regulated proteins, and diabetes increase the binding of mannose binding lectin. So complement is activated, and when complement is activated, mannose binding lectin is activated, it activates intracellular signaling pathway, which leads to release of pro-inflammatory cytokines and growth factors. If we look here, this is the impact of complement activation. You can find here increasing polyol pathway, increasing protein kinase C pathway, and a lot of mediators are stimulated by the binding of complement. So this is within the diabetic environment. One of interesting issue is hydrogen sulfide. Hydrogen sulfide is a gas which is bad and toxic and may even lead to fatalities or neurotoxicity according to the concentration. However, this, if we say this is the environment of diabetes that can lead to diabetic kidney disease and diabetic nephropathy, increasing inflammatory pathways, reactive oxygen species, and renal injury pathways that ultimately lead to diabetic nephropathy. Hydrogen sulfide was proven to be a good friend because it inhibits all these pathways. So hydrogen sulfide inhibit inflammatory pathways and inhibits reactive oxygen species production and oxidative stress. This will ameliorate renal protection. The most important point is we cannot give the patients hydrogen sulfide gases because I mentioned it is toxic. So it's better to search for a producer and donor of H2S. The donor of hydrogen sulfide, the physiological and from the nutritional point of view, is garlic. So garlic may be a friend to protect against diabetic nephropathy, but we cannot know how much of garlic to be used to reach this and to inhibit all these bad issues of inflammation and reactive oxygen species. So I think research in this field is important and exciting. Another, thiosulfate, and in the nephrology field, we know the role of thiosulfate in management of calciphylaxis. The major problem is thiosulfate should be given intravenous because thiosulfate will be destroyed by gastric HCl. So there is a thinking to develop an oral thiosulfate encapsulated to avoid damage of HCl. So are waiting a research in this field. And there is a phase 1 clinical trial assessing the H2S donor SG1002 in this issue. So again and again, there is a role of hydrogen sulfide. Regarding cadmium induced nephropathy, diabetic nephropathy, from the metabolomic, this is a metabolomic study assessing this issue. So we have cadmium and high sugar and high fat diet, and this is the CAPE, which can be given to ameliorate the effect. CAPE is an active component of propolis from honeybee hives. And here the pathology is ameliorated by this CAPE, and CAPE is caffeic acid phenethyl ester. This is the name of CAPE. And the CAPE, as you see, can target many pathways in the oxidative stress and the inflammatory pathway to ameliorate diabetic nephropathy. So again and again, CAPE may be potential to target inflammation and oxidative stress. All of us know the link between hepatitis C and diabetes. So hepatitis C virus is a risk factor for diabetes in general. And moreover, HCV has its bad effect on the kidney. So it seems the presence of direct antiviral antihepatitis C may it change the map and of the link of hepatitis C and diabetes. So hepatitis C leads to chronic inflammatory state, insulin resistance, cardiovascular risk factors, and cardiovascular disease with implication of the kidney, and may affect the kidney by immunological pathways, as we know. Regarding the adiponectin, this is the study on adults with type 1 diabetes. Here, this is the 646 patients at baseline and 525 patients after 6 years. Here, there is a correlation between adiponectin and diabetic nephropathy. So adiponectin is associated with higher risk of the kidney. So this is according to multi-variable model predicting rapid glomerular filtration decline, incident chronic kidney disease, and persistent diabetic kidney disease over 6 years. Here, this is the different models adjusted according to age, sex, duration, adjusted for age, sex, and other factors. So All these are different models, and you can look at the key here. This is for this and this and this. Again, high adiponectin is associated with poor kidney. So if we look at adiponectin, is it a friend or foe? Look at this cartoon. All these are pathways for inflammation and targeting the issue of diabetes and the kidney, leading to chronic kidney disease. If you look here, adiponectin has a protective effect against the effects of high glucose and inflammation in the angiotensin II pathway. So why adiponectin in the previous slides was associated with increasing the risk of diabetic kidney disease and occurrence of advanced chronic kidney disease? This may be because of adiponectin resistance. So adiponectin resistance is well known today, and if we know the problem is the adiponectin resistance, we may have a drug that stimulates adiponectin receptors. So the presence of agonist of adiponectin receptors may ameliorate the pathology of diabetic kidney disease. Another important point, which is vasopressin and its relation to diabetic nephropathy. So in this cartoon, you can find vasopressin stimulate V2 receptors on collecting duct, leading to all these and the impairment of tubular feedback, leading to increasing glomerular filtration, increasing albumin excretion and renal hypertrophy, and limiting water loss. So all these will lead to progressive nephropathy. So either giving water to regulate vasopressin or by giving specific drugs, we are waiting further research. Another hot axis in the pathophysiology is kallikrein-kinin system in diabetic kidney disease. Kallikrein binds kininogen here, binds type 1 receptor and type 2 receptor bradykinin. So binding these receptors will lead to amelioration of inflammation and oxidative stress and protecting against diabetic kidney disease. So the recent evidence suggests that kallikrein-kinin system has protective effects on various kinds of renal disease, especially diabetic kidney disease. Through activating the bradykinin B2 receptors and the B1 bradykinin B1 receptors, kallikrein-kinin system is believed to delay or reverse the onset of diabetic kidney disease by inhibiting renal oxidative stress and inflammations, protecting endothelial cell function and decreasing fibrosis. Activation of this system by exogenous supply with kallikrein has treatment potential in patients with diabetic kidney disease, which warrant further clinical trials. Another hot issue in the pathogenesis of diabetic kidney disease is hypoxia. Renal oxygenation in the pathophysiology of chronic kidney disease is discussed in this study, in this paper. Here, the increasing renal blood flow, sodium retention in the presence of hypertension, all these lead to increasing tubular absorption, increasing oxygen consumption, and this will lead to tissue hypoxia and subsequent chronic kidney disease with these different pathways. So if we look at hypoxia inducible factor stabilization and increasing, we know now that hypoxia inducible factor boryl hydroxylase inhibitors, which are used in the management of renal associated anemia, may have good impact on anemia management. So we are waiting to look at this, the using of these pathways of dealing with hypoxia inducible factor and the evolution of chronic kidney disease. Here I want to stress upon that we have tubular and glomerular discordant activities of hypoxia inducible factor. So on tubules, hypoxia inducible factor inhibition leads to tubular interstitial fibrosis and albuminuria. So stabilization of hypoxia inducible factor here may have good impact on the tubular interstitial compartment. By increasing the activity of hypoxia inducible factor on the glomeruli may lead to sclerosis. So if we can deal with the tubular hypoxia-inducible factor, sparing the glomerular hypoxia-inducible factor, this may be interesting in addressing this issue. So are waiting. So diabetes results in decreased kidney oxygenation, which contribute to the onset and the progression of diabetic kidney disease. Diabetes increases hypoxia-inducible factor 1 alpha activity in glomerular mesangial cell, causing glomerulosclerosis. This is why we may even think to inhibit this pathway in the glomeruli. Diabetes prevent normal hypoxia, induced hypoxia-inducible factor activation in tubules, leading to abolished normal cellular response to chronically reduced oxygenation. Pharmacological hypoxia-inducible factor activations, especially in the tubules, targeting only the tubular sector of hypoxia-inducible factor, prevent diabetic kidney disease in experimental animal models. Ongoing clinical trials using non-selective and selective prolyl hydroxylase inhibitors to treat renal anemia. Selective means in the tubules. May provide novel insight regarding the role of differential role of hypoxia-inducible factor signaling in chronic kidney disease. However, the benefit of modulating hypoxia-inducible factor signaling in diabetic kidney disease will still require additional time and effort to solve the current controversy. Endothelin A receptor antagonist in diabetic kidney disease means the endothelin A stimulation is bad, and the balance between the renoprotective properties of endothelin antagonist and the risk related to a fluid retention in diabetic kidney disease under investigation in ongoing phase 3 clinical trials to prove the value of endothelin receptor antagonist. Currently, we have MD thesis for MD nephrology for Dr. Summer about manipulating the autophagy pathways in diabetic kidney disease. So we are working in the animals to reach this issue. Does manipulation of autophagy can help in ameliorating diabetic kidney disease? Because a lot of controversial issues and the pathways are there linking the autophagy dysfunction with diabetic kidney disease. Regarding the diabetic kidney disease presentations, to start the presentation, it's important to look at this natural history, and this natural history is best fitting with type 1 diabetes, because in type 2 diabetes you can find discordance because we cannot be sure of the timing of the occurrence of renal dysfunction. So here, this is the years of hyperglycemia, and then it will be concordant with this is the kidney function. In this time, in these years, you'll find high GFR, then normal GFR. This means that hyperfiltration issue here decline, and then at the end GFR decreases and end-stage kidney disease will develop. So this is the evolution of kidney function according to the time scale after the occurrence of type 1 diabetes. It occurs with type 2 diabetes, but the time is not perfect like this. And this is from cellular pathology, cellular injury, mesangial expansion, sclerosis, and tubular interstitial fibrosis and damage. And this is a urine analysis, microalbuminuria and macroalbuminuria, or M2 and M3. And then this is the cardiovascular disease, infection and death occurring within the evolution of diabetic. And here, kidney complications starting from decreasing GFR down to end-stage kidney disease. So the starting point is hyperfiltration. Hyperfiltration is variable in type 1 diabetes from 10% to 67%, and in type 2 diabetes from 60% to 73%. And you can look here, because hyperfiltration means that we have normal reserve that is hidden within the kidney, and the kidney, when is stressed, it works maximally, leading to hyperfiltration. And after a period of time, here you will find increasing urine albumin excretion and the GFR decline. So GFR decline and the proteinuria increases. I want to focus on hyperfiltration. Hyperfiltration means that normally the kidney has renal function reserve that is stimulated by hyperglycemia and diabetes, and it can be tested by giving the patient amino acids and measuring GFR before and after amino acid, or by giving high oral diet from the white egg, 1 gram per kg, and then measuring creatinine clearance before and after. The difference will be a representative of the residual renal reserve, renal function reserve. So if we look here, if we are starting with 120 milli per minute, and after a period of time you'll find GFR is 120 milli per minute, but with the price of losing kidney function nephron, so although here it's 120 and here is 120, but at this point the kidney function, the function nephron mass is reduced by 50%. And here you can find here, this is the starting point in hyperfiltration. The nephron here is 100%, and at the end of this phase, nephrons become tired, and then you'll find the loss of some of nephron, and by the time we reach end-stage kidney disease. So if we work on the hypothesis of hyperfiltration and we can ameliorate the hyperfiltration, we may do better in diabetes. So factors leading to afferent dilatation and efferent spasm in diabetes can lead to hyperfiltration. So because normally the filtration pressure is mainly determinant on hydrostatic pressure that's controlled by the difference in the lumen of afferent and efferent. So normally efferent is little bit constricted, but in diabetes the afferent is dilated more and more, and the efferent is constricted more and more. So all these factors, either vascular factors or inhibition of tubular glomerular feedback, are factors beyond the afferent dilatation. And increasing angiotensin II, thromboxane, endothelin, A receptor activation, reactive oxygen species, all these factors can lead to efferent arteriolar more and more constriction. This means increasing efferent arterial resistance. So if we can know how to manage these issues and to can improve the issues of diabetes and prevent the damage of kidney in these patients. One of the most important points is we have nowadays a terminology, silent diabetic nephropathy. This means you'll find normal creatinine, normal urine analysis, but the pathophysiology of diabetic kidney disease is evolving. So how to protect? This is one of the pathways to look at urinary biomarkers like NGAL, cystatin C. This is a study including 146 type 2 diabetes patients with a disease duration of more than 6 years. So urinary NGAL and cystatin C precedes albuminuria. Another way is by using the advances in the MRI, so arterial spin labeling, measuring renal blood flow. Here you can find, in comparison to the normal, you can find here diminished renal perfusion. So this is renal blood flow, milli per minute per 100 gram renal tissue. If this is the normal, this is a diabetic person. And if we look at different stages, the higher the stage of chronic kidney disease, the lower the renal blood flow. So again and again, this modality may help in predicting. And another important point in follow-up of patients with diabetes is to look at the rate of declining, because every person has its unique evolution. So the rate of declining of kidney function is different from a person to person. So we have very fast progressor, fast, moderate, and slow decliner. According to the slope, if GFR dropped by more than 15 milli per minute per year, this is a very fast, or between 10 to 15 it is fast, moderate about from 5 to less than 10, and slowly less than 5 milli per minute per year, per average 1.73 square meter. So if we are dealing with very fast decliner, we can predict occurrence of end-stage kidney disease in 2 to 5 years to 6 years. This means we should address the risk factors and aggressively manipulate them to avoid this very fast progression. And if we are dealing with those who are fast decliners, so the end stage can occur within 6 to 10 years, moderate decliner 10 to 20, and if we succeed even to ameliorate the rate of decline to changing very fast to slower, we can reduce the rate of the development from 2 to 6 years to 20 years if we succeed. So it's better to personalize our medicine by risk factor modification according to the status of progressive renal disease. And the secret of success is to deal early. So if you deal early, you can change the slope of progression. But if you deal late, late is late. So it's better to start treatment early to target the state of progression. And if we succeed to change the rate of progression from very fast to fast or even to moderate, or it's better to be slow or very slow, this will be a real success in management of these patients. Another important issue, how to predict the occurrence of diabetic end-stage kidney disease and diabetic kidney disease or diabetic nephropathy. From Joslin cohort, the TNF receptor exceeding 4.3 nanogram per ml, it was proven to be a single criterion predicting the occurrence of end-stage kidney disease. Suppose that we have TNF receptor 1 between 2.9 to 4.3, we need albumin creatinine more than 1.9 gram. So either to have the TNF receptor exceeding 4.3, this is a very interesting predictor and criterion that may improve the clinical study to address the prediction of end-stage kidney disease. Or if TNF receptor type 1 is in the range between 2.9 to 4.3, we need another factor which was proven to be important, which is albumin creatinine ratio exceeding 1.9 gram per day. 1.9 gram per gram creatinine. Another interesting advances in technology and in diagnosis, which is urinary peptide-based classifier CKD273, which is the application of proteomics. Because when we apply proteomics, here if this is a healthy person, and then with evolution of development of diabetes or any disease, this will have molecular alteration that can be diagnosed by proteomics. So if we wait until the late, this you will seek for the parameters or indicators of advanced damage or organ failure, and this is not good. So if we want to change, it may be through looking at the urine to detect the proteomics or protein or peptides that can refer to evolution of the disease toward the advanced stages. So if we start early, if we detect early and intervene early, this may be beneficial. And this is regarding the FDA milestones of CKD273 implementation. Here you can find a letter here at the end of the day. There is a letter of support. And this is a study, IMPRESS, addressing the issue of cost effectiveness of screening type 2 diabetes patients for chronic kidney disease progression with CKD273 urinary peptide classifier as compared to urinary albumin excretion. And here, if there is high risk of other risk for cardiovascular and kidney, it seems that it's, the cost here, the effectiveness is valid. But if there are no other risk factors, it seems that this is still expensive. So we are waiting more and more refinement of the technology. And if we have refined the technology, this may help us to predict the disease from early beginning. And at that time, we may succeed to halt the progression of the disease. This is a study that is the most recent study that was published on July 21, and it addressed the use of proteomics to investigate kidney function decline over 5 years. And the patients included the majority are non-diabetic. So this is the prospective investigation of the vasculature in Uppsala senior study, BIVAS, and ALSAM, the Uppsala longitudinal study of adult men. So these are two cohorts. and in the first cohort PEVAS, including 687, mean age of the patient 70 years, and 51% are women. And the ALSAM, 360 men, aged the mean age of 78 years. And diabetes in each cohort, it's approximate 11%. So the majority are non-diabetic. And when we look at the whole cohort, we can find here all these are proteins, 20 proteins that can refer to decline of the kidney function. And this is a list of 20 proteins that were significantly associated with estimated GFR decline in both cohorts in the order. And you can find letter A here is associated with CKD incidence. So it's if we look at these proteins, the NF-related apoptosis inducing ligand receptor 2, CD40 ligand receptor, soluble to NF receptor 1, plasma growth factor, thrombomodulin, urokinase plasminogen activator surface receptor, growth differentiation factor 15, macrophage colony stimulating factor 1, fatty acid binding protein 4, cathepsin D, resistin, kallikrein 11, CC motif chemokine 3, proteinase activated receptor 1, cathepsin L, and others. So if you fix this is the protein name in order of significance. This is the acronym, and this is the protein identification number. All these are associated with prediction of kidney decline. And this is the editorial comment in the possibility to improve kidney health with proteomics. And this is the key conclusion. In summary, proteomics is expected to give important contributions to clinical nephrology in the coming years. Admittedly, similar statements have repeatedly been put forward over the last 10 years. So the same statements are stated since over the last 10 years. What is new today? But the technology is now further refined, simplified, and more available. And so, hopefully, we will begin to see proteomics-based diagnostic and therapeutic products incorporated into clinical care, as stated by the editorial comments. So we are waiting more and more refinement of the proteomics, and to have the technique available everywhere, to have a lot. I think this is from the pathogenesis. This is targeting endocannabinoid system, and this is the issue combining therapy for these pathways. And I think this slide can be put in the management or in the pathogenesis. Regarding total bilirubin, the lower the serum bilirubin, the higher the risk of evolution of chronic kidney disease, because total bilirubin function normally is against the oxidative stress. So whenever you find serum bilirubin is very low, less than 0.3, this means that the oxidative stress is high. So if you compare serum bilirubin less than 0.3 to 0.6 or above 0.6, patients with serum bilirubin less than 0.3, the risk of evolution of kidney disease is more and more high in this population. So we can look at serum bilirubin as a predictor of evolution of kidney disease. Another test, which is high sensitive troponin T in type 1 diabetes cohort of 442 without and 458 with diabetic nephropathy, plasma high sensitivity troponin T predicts end-stage kidney disease and cardiovascular disease and all-cause mortality in these patients with type 1 diabetes and diabetic nephropathy. So this is the cohort, and this is a correlation with the annual change of estimated GFR. The higher the quartiles of high sensitive troponin T, the higher the decline in GFR, and this is the hazard ratio for all-cause mortality. For doubling in high sensitive troponin T level at baseline, here you can find how hazard ratio is increasing with the higher high sensitivity, and without nephropathy and with nephropathy you can find here, this is if nephropathy is there, the hazard ratio is increasing by increasing high sensitivity troponin T. So this may play a role in prediction. Another clinical parameter which is looking at the presence or absence of retinopathy. So here, if you look here, for higher risk of end-stage kidney disease, odds ratio of rapid renal progression, higher risk for all-cause mortality. And here we are looking at the presence of diabetes more than 8 years, so this is a clinical history, and the presence of diabetic nephropathy. So the presence of diabetic nephropathy increases the hazard risk for end-stage kidney disease, either unadjusted or adjusted. Here you can find this is the hazard risk for end-stage kidney disease for the presence of diabetic nephropathy. The odds ratio for rapid renal progression is increased, either unadjusted or adjusted, fully adjusted, and the all-cause mortality increased as well. So in the clinical work, if we have a patient who is diabetic and there is albuminuria or proteinuria, we advise for fundus examination to search for the presence or absence of retinopathy. And the presence of retinopathy assures that we are dealing with diabetic nephropathy. So, but this just to show you that the presence of retinopathy is not good, is not associated with good outcome, but it's associated with poor outcome because it's associated with higher risk of end-stage kidney disease, rapid renal progression, and all-cause mortality. The presence of diabetic kidney disease and early kidney disease and diabetes is associated with the cognitive dysfunction and abnormality in MR, either in white matter or gray matter. It may be correlated with the modified mental state and with homocysteine. So if you look here, if the SMGFR is reduced, homocysteine is increased, and the cognitive dysfunction is there. This is an interesting study looking at the impact of the presence of chronic kidney disease in diabetic persons and the outcome of these eluted stents, either piolimus, everolimus, or zotarolimus. The presence of CKD is more important, and the CKD affects the patient outcome irrespective to the type of the eluted stent used. One of the important points in the clinical management of diabetes is to look at the variability. We don't like variability in A1C, blood pressure, lipid parameter, serum uric acid, all these risk factors, and the variability in these variables may be associated with development of chronic kidney disease and complication. So we should be sure that we are treating the patients, avoiding variabilities in all these issues. So here the number of patients, 4,231 evaluated for development of albuminuria and 7,000 for decreased estimated GFR. The variability is poor and bad. Regarding pathology, this is one of the important points to be thought. Here, if we look at this, in comparison to the normal glomerulus, you can find here the diameter of the basement membrane. Look here, A refers to the presence of mesangial thickening, and B is thickened basement membrane, and C refers to the abnormality within the podocytes, so indicate segmental effacement of visceral epithelial food process. So this is electron microscope, and here you can just look and compare to the normal glomerulus. You will find here mesangial expansion, a very thickened basement membrane here, 1,000 more in comparison to 300 here. So it is very clear that diabetes is associated with the thickened basement membrane, but there is no deposits here. So this is the diabetic nephropathy. And this is a light microscope showing that the pathology in different stages. So A is a normal glomerulus, B is the diffuse mesangial expansion with mesangial cell proliferation, and C prominent mesangial expansion with early nodularity and mesangiolisis, and D is established nodular sclerosis So accumulation in the form of cumulostyle Wilson nodules of mesangial matrix. So it is nodular type, and then this is the dilatation of the capillaries forming microaneurysms. All these are microaneurysm, and this is the obsolescent glomerulus. So all these are stained with BAS stain except this part of the slide, which is stained with Jones stain. So again, all these are factors. So how the pathologists look at the slides of diabetic nephropathy? Diabetic nephropathy is classified into 4 stages. The pathologists start with looking at if there is or not advanced glomerulosclerosis. If there is advanced glomerulosclerosis, stage 4. So he will find, or she will find, global glomerulosclerosis in more than 50% of glomeruli lesions from class 1 to 3. So this is the, so if we have global sclerosis, it's a stage 4. If there is no global sclerosis, we search for the presence or absence of nodular sclerosis, Cumulostyle-Wilson nodules. At least one convincing Cumulostyle-Wilson lesion, biopsy done to meet criteria of for class 4, because if there is class 4, it's class 4. So if there is no global sclerosis and just nodular sclerosis, it's nodular sclerosis or stage 3. If there is no nodular sclerosis and there is mesangial expansion more than 25% of observed mesangium in the biopsy, provided that there is no criteria 3 and 4, it is a stage 2B. But if it is less than, this is less than 25% of observed mesangium is affected by mesangial expansion, it is 2A, provided that we don't have 3 or 4. But if there is no 4, 3, or 2 criteria, just we have second basal membrane exceeding 395 nanometer in women and 430 in men, this is stage 1. So the diabetic nephropathy pathology, the classic, is divided into 4 classes, either 1, 2A, 2B, and 3 and 4. According to 1 is just thickened basal membrane, 2 either A or B is thickened mesangium. If it is less than 25% of the mesangium, it is 2A, more than 25% is 2B. Nodule, it is nodular sclerosis class 3. Global sclerosis is advanced diabetic glomerulosclerosis. So this is an example of diabetic glomerulopathy. It changes in glomerular histology in diabetic patients. A is normal glomerulus. B is diffuse mesangial expansion with mesangial cell proliferation. C this is the normal glomerulus. This is a second tubular basal membrane, and this is hyaline thickening of the vessels. So this is hyaline lesion in the vessels, and this tubular atrophy as referred by this arrow. Again, as we looked at the glomeruli 1, 2, 3, 4, here we look at the type of lesion in the interstitium and tubules. So we look at IFTA, interstitial fibrosis tubular atrophy, either absent, less than 25% is 1, between 25 to 50 it is 2, above 50% is 3. Interstitial inflammation absent, infiltration only in relation to IFTA 1, infiltration areas without IFTA is 2. Vascular lesion, arterial hyalinosis, absent 0, at least one area of arterial hyalinosis 1, more than one area of arterial hyalinosis 2. Presence of large vessel arteriosclerosis, no intimal thickness 0, intimal thickening less than thickness of the media is 1, intimal thickening greater than thickness of media is 2. So this is the score for the lesions in the tubular interstitium and the vascular lesion. Again, this is the tubular atrophy, and this is the thickening of the tubular basal membrane, and this is arterial hyalinosis. The question is, should you do biopsy for all patients? I think as a physician working in the field of nephrology, we'll look at the clinical. So if we have macroscopic hematuria, not microscopic, because microscopic hematuria can occur within the domain of diabetic nephropathy. So if we are expecting pathology superimposed on diabetic nephropathy, from the clinical point of view, we look at macroscopic hematuria. we look at rapid progressive renal failure in a patient with diabetic, because rapid progression is not, renal failure is not the characteristic of diabetic. Absence of retinopathy, atypical history of diabetes, and we may find persistent nephrotic syndrome in absence of, in the presence of normal creatinine, because in the natural history, if we have established and persistent nephrotic syndrome, we should have low GFR and higher creatinine. So in all these are classic indications from the clinical point of view to do biopsy. But if we decrease the threshold of doing a biopsy in our patient, it may be accepted. Because if we look at this very big cohort of patients, look here at the different causes of nephrotic and glomerular disease. If you look here for glomerulosclerosis, it increased from 5.5% in this time period to 11 to 19. So if we look at the total number of the patients in this cohort, the 14.2% of the patients have diabetic glomerulosclerosis. So glomerular disease is due to diabetic glomerulosclerosis. So it seems that diabetic glomerulosclerosis is increasing, and there is temporal trends in epidemiology of biopsy-proven glomerular disease, an alarming increase in diabetic glomerulosclerosis as stated by the editorial comment. And again, yes, we may do biopsy and we find diabetic nephropathy, or we have non-diabetic renal disease on top of diabetic patient, or non-diabetic renal disease. So here I want to fix this statement. If you have the pathology classic of diabetic nephropathy, 5-year renal survival is lower. So 5-year renal survival in the presence of diabetic nephropathy as pure pathology, it is only 55%. But if we are dealing with non-diabetic renal disease, like other pathologies, the expected 5 years survival may be exceeding 90%. And if it is even superimposed on diabetic nephropathy, it's also associated with good 5-year renal survival. Patient with doubling of creatinine in diabetic nephropathy is here. This is the issue. This is without doubling. So without doubling of creatinine, it will be higher, because without doubling is only 36%. This means that 60%, 64% will have doubling of creatinine, and the doubling of creatinine will be lower in the presence of non-diabetic renal disease. So it is better to look at the biopsies, because if we detect non-diabetic kidney disease either alone or superimposed on diabetic nephropathy, and we target this non-diabetic renal disease by specific treatment, it may keep the kidney function, and the 5 years survival and avoiding doubling of creatinine will be high in these domains, non-diabetic renal disease or non-diabetic superimposed on diabetic nephropathy. In comparison to clear diabetic nephropathy is associated with poor 5-year renal survival and higher percent of doubling of creatinine. Again, and from renal survival point of view, the higher the sclerosis of glomeruli, the higher, the lower the renal survival, and the higher the rate of declining of the kidney function, and the higher state of doubling of creatinine. Again, this is a biopsy showing the presence of deposit either within the membrane or subepithelial. So this is membranous nephropathy superimposed on diabetic patient. One of the important sectors within this presentation is diabetes after living kidney donation. So risk factors for post-donation diabetes is obesity, and smoking. So we should educate our donors after donating their kidneys is to avoid gain of weight and to adopt the healthy lifestyle to avoid obesity and to avoid smoking at all, because these factors are bad. And then this is another issue, obesity in live kidney donors. So obesity in live kidney donor will be associated with not only occurrence of diabetes, but the increase in the risk for end-stage kidney disease after live kidney donation. If we look at this cohort of patients, this is a patient whose body mass index exceeding or equal 30 kilogram per square meter or less than 30 kilogram per square meter. If you look at the end-stage kidney disease according to the interval here. If you look here, after 20 years, in obese exceeding or equal 30 kilogram per square meter, here the cumulative incidence is 93 per 10,000 living kidney donor. But if there is no obesity, it drops to 39 only. So again and again, we should educate, and the curve here is clear. In obese, the risk of occurrence of end-stage kidney disease per 10,000 donor increased significantly because of obesity. What about the renal consequences of diabetes after kidney donation? So long as we are addressing risk factors like obesity and smoking, this will decrease the risk of diabetes. So here's the risk of diabetes in this study was 7.7%. And here, according to the renal outcome, if we are dealing with no diabetes after kidney donation, everything is fine here. But if the diabetes alone will reduce renal survival, and renal survival is reduced drastically if another factors are added to diabetes, like hypertension and proteinuria, and patients with or donors with lowest kidney function and lowest estimated GFR are donors who develop diabetes, proteinuria, and hypertension. So we should put all this in our mind. And this again, if no diabetes and diabetes after kidney donation, diabetes after kidney donation is associated with poor renal outcome. To conclude this presentation, again, this will be the introduction for the treatment for this next presentation, and I'd like to remind you by the pathophysiology defect of diabetes, which from the therapeutic point of view, because we have current treatment, existing glucose lowering therapy, and future therapy that are tested in the phase 1 and phase 3, and we are waiting the evidence base for the newcomers for the management of diabetes. So the pathophysiology either defect in pancreatic beta cell, loss of cell mass and function, and here the treatment for type 2 diabetes, sulfonylurea and hemagglutinin. All these are insulin secretagogues, and we are waiting hemagglutinin to be proved to be advantageous in the management of this pathophysiology of diabetes. So this is a pathophysiological defect of diabetes. We have 11 pathophysiological defects for diabetes in general, type 2 diabetes. Or abnormality in pancreatic alpha cell, dysregulated glucagon secretion, increased glucagon concentration. So we have GLP-1, glucagon-like peptide 1 receptor agonist, and we are waiting glucagon receptor antagonist in the future. Incretin, diminished incretin response, and we have glucagon-like peptide 1 receptor agonist or DPP4 inhibitors, and in the future oral GLP-1 receptor agonist, once weekly DPP4 inhibitors. Inflammation, immune dysregulation. So these parameters, the glucagon-like peptide 1 receptor agonist and the DPP4 inhibitors, have anti-inflammatory. In the future, we may have immune modulator anti-inflammatory agents that to be proven to be effective. Liver defects, increase hepatic glucose output. The current treatment working on this pathway, metformin and pioglitazone, and we are waiting the issues and the benefits of glucagon receptor antagonists in the future. Regarding muscle defects, reduced peripheral glucose uptake, insulin resistance, metformin and pioglitazone work in this issue, and these are current treatment, and selective PPAR modulators may be in the future. Adipose tissue abnormalities, reduced impaired peripheral glucose uptake, insulin resistance, metformin and pioglitazone work on this pathway, and we are waiting selective PPAR modulators, FGF21 analogs, fatty acid receptor agonist. All these may help. Kidney defect, increased glucose reabsorption caused by upregulation of sodium glucose cotransporter 2, and nowadays we have sodium glucose cotransporter 2 inhibitors, and we are waiting in the future the combined effect of sodium glucose cotransporter 1 and 2 inhibitors. In brain, and the brain is behind everything, increased appetite, lack of satiety. The GLP-1 receptor agonist works on this, but GLP-1 glucagon gastric inhibitory peptide dual or triple agonist may be the future treatment. Stomach or intestine, increased glucose absorption, and we are waiting here the GLP-1 receptor agonist, DB4 inhibitors, alpha glucosidase inhibitor, and this drug work on this issue nowadays. We are waiting the validity of sodium glucose transporter 1 inhibitors. Colon abnormal gut microbiota. And these are drugs work on this issue, and we are waiting in the future the feasibility of probiotics. And here I remember a very nice study that was published since a couple of months, showing that early use of antibiotics in the neonate, in the neonate, is bad because it disturbs the gut microbiota. So we should avoid the abuse of antibiotic in this early life. And another important point is to encourage women to sufficient breastfeed their babies, because the longer the duration of breastfeeding, the proper the gut microbiota. So all these are the pathophysiological defects, 11 pathophysiological defects in pancreatic beta cell, alpha cell, incretin, inflammation, liver, muscle, adipose tissue, kidney, brain, stomach, or intestine, and colon. And I summarized the current treatment available and the future treatment. And in the next presentation, which will include all these issues and other issues in the management of diabetes and diabetic kidney disease, I'll discuss some of these treatments in details. So I would like to end with this favorable quotation by William Osler, who is the father of medicine. He who studies medicine without books sails on uncharted seas. This means the sea is not known, so he can be confronted with problems. But he who studies medicine without patience doesn't go to sea at all. This means to work as efficient physicians, we should learn, have a good training, and work with patience. And at the end of the day, we will build our experience. So reading, training, working with the patients meticulously, this will make a big difference. Thank you for attention, and I'll be happy to have your questions on my email. Thank you. Goodbye.